Hello everyone, I am Dr. Sarita Jain. In today's video, I am going to discuss about the hypertensive disorder in pregnancy. This is a very common condition and its overall incidence is about 5 to 10%. This is the most frequent cause of the iatrogenic prematurity. This condition is also associated with preterm delivery, intrauterine growth retardation, perinatal death, maternal cerebrovascular accident and placental abruption. Hypertensive disorder during pregnancy are categorized mainly into 5 types. First is chronic hypertension. In this, there is high blood pressure before pregnancy or before 20 weeks of the pregnancy, possibly with added preeclampsia or eclampsia. Second is gestational hypertension. In this condition, high blood pressure starts usually after 20 weeks of the pregnancy. Third is HELLP syndrome. This is a severe form of preeclampsia with hemolysis, elevated liver enzyme and low platelet count. Next is preeclampsia. In this, high blood pressure and signs of damage to other organs are present, which can be with or without severe features. Next is eclampsia. This is a severe form of preeclampsia that includes seizures. Now, what are the causes of hypertension in pregnancy? There are certain conditions which reduces the uteroplacental blood flow. In these conditions, there is high risk of the hypertension during pregnancy. These conditions are if there is pre-existing hypertension before pregnancy, if there is renal disease or diabetes mellitus or obstructive sleep apnea syndrome, or there is thrombophilia or autoimmune disease, then in all these conditions there is high chances of having hypertension during pregnancy. Now there are certain risk factors also which are when present there are high chances of the hypertension during pregnancy. These are if there is previous history of preeclampsia or HELLP syndrome, if it is twins or multiple pregnancy, if BMI is above 30, if there is autoimmune disease, age is over 35 years, if this is first time mother, or there is family history of gestational hypertension. These all factors elevate the risk of developing gestational hypertension and increases the chances of it progressing to preeclampsia. Prevalence of hypertensive disorder is about 5 to 10% of all pregnancies. Preeclampsia affects 2 to 8% of the pregnancy worldwide. Now, what is the trend in US? The rate of preeclampsia increased by 25% from 1987 to 2004. This rising rate of hypertension is mainly due to changing maternal demographics such as older maternal age and higher pre-pregnancy weight. But the incidence of eclampsia has decreased due to improved prenatal care, increased use of the antenatal therapies like blood pressure control and magnesium for seizure prevention. Timely delivery through induction of the labor or cesarean section has significantly reduced the incidence of severe preeclampsia and eclampsia. Now, what is the pathophysiology of the hypertension in pregnancy? Exact cause of the hypertension in pregnancy is not fully understood, but inadequate trophoblastic invasion is the most crucial thing required for the development of the hypertension during pregnancy. This involves abnormal regulation and production of certain regulators. These are cytokines, adhesion molecules, major histocompatibility complex molecules and metalloproteinase. Abnormal regulation of the molecules leads to the improper development and remodeling of the spiral arteries in deep myometrial tissues. This leads to the placental hypoperfusion and ischemia. Main organs affected in hypertension in pregnancy are eyes, lungs, liver, kidney and peripheral vasculature. In chronic and gestational hypertension, systolic blood pressure is more than 140 and diastolic blood pressure is more than 90. In severe hypertension, systolic blood pressure is more than 160 and diastolic blood pressure is more than 110 mm of Hg. Most common symptom in preeclampsia is increased body swelling, that is increased body edema. Severe features of preeclampsia are mainly related to various organs like cerebral symptoms are severe headache, altered mental status. Visual symptoms are scotomata, photophobia, blurred vision, temporary blindness or visual field defects. Symptoms of pulmonary edema can be there. These are shortness of breath, rales. There can be renal impairment which leads to water retention and causes peripheral edema. There can be hepatic impairment and right upper quadrant pain because of the hepatic involvement. HELLP syndrome symptoms are malaise, right upper quadrant pain, which is present in up to 90% of the cases. There can be vomiting also. Now, how to diagnose hypertension during pregnancy? For the diagnosis of chronic hypertension, systolic blood pressure should be more than 140 and diastolic blood pressure should be more than 90 mm of Hg. And blood pressure should be measured at least 2 times 4 hours apart for the diagnosis of chronic hypertension before 20 weeks of the gestation. For the diagnosis of gestational hypertension, ACOG guidelines are used, and diagnostic criteria is systolic BP should be more than 140 and diastolic should be more than 90 on 2 occasions at least 4 hours apart after the 20 week of the pregnancy with previously normal BP. There is immediate confirmation of hypertension if systolic BP is more than 160 and diastolic BP is more than 110 mm of Hg. Severe BP usually presents with the clinical symptom and it indicates potential and organ damage. Now, diagnostic criteria for the preeclampsia. For this, ACOG guidelines are used, and in this there is hypertension with more than 300 mg urine protein in a 24-hour period, or protein to creatinine ratio is more than 0.3. If this is not measured, then a urine dipstick with protein reading of at least 1+1 is required. If proteinuria is not there, then for the diagnosis of preeclampsia, there is new onset hypertension with one or more of the following is required. If there is thrombocytopenia, that is platelet is less than 1 lakh per microliter. If there is renal insufficiency, means serum creatinine is more than 1.1 milligram per deciliter, or there is pulmonary edema or impaired liver function, or there is persistent headache unresponsive to medication, then it can be diagnostic of preeclampsia. It can occur with chronic hypertension or progress from the gestational hypertension. Next is eclampsia. It occurs in preeclamptic patients who develop generalized tonic-clonic seizures. It typically occurs intrapartum to 72 hours postpartum due to untreated or undertreated preeclampsia. Its incidence is about 2 to 3% in severe preeclampsia and 0.6% in preeclampsia without severe features. Maternal complications can occur in up to 70% of the cases with morbidity as high as 14%. Next is HELLP syndrome. This is the severe form of preeclampsia, and diagnostic criteria according to ACOG are hemolysis, that is LDH more than 600 IU per liter. There should be liver injury, AST LT should be more than 2 times upper limit. There should be thrombocytopenia, that is platelets less than 1 lakh microliter. Now, treatment of the hypertensive disorder in pregnancy. Aspirin prophylaxis can be given for the prevention of hypertension. It is started between 12 to 28th of the week of the pregnancy and can be continued up to the 36th week for those with one high risk factor and for those who have 2 moderate risk factor. So, what are the high risk factors? High risk factors are if there is history of preeclampsia, chronic hypertension, type 1 or 2 diabetes, renal disease or autoimmune diseases, multifetal gestation. Now, what are the moderate risk factors? Moderate risk factors are nulliparity, that is first time pregnancy, more than 10 years between pregnancies, if BMI is more than 30, low socioeconomic status, African American race, and if there is family history of the preeclampsia in a first degree relative, or if there is advanced maternal age, that is age more than the 35 years at the time of delivery. If there is history of intrauterine growth retardation, previous adverse pregnancy outcome, these are all moderate risk factors. So, if one high risk factor or two moderate risk factors are present, then aspirin prophylaxis is indicated. Now, what is the treatment for hypertension? First line treatment for hypertension is labetalol, hydralazine or nifedipine. Nifedipine is preferred for acute oral treatment and in outpatient settings. Thiazide diuretics can be continued if they were used pre-pregnancy. Try to avoid ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists and nitroprusside. Nitroprusside can be used as a last resort. Treatment goal is to achieve systolic BP 140 to 150 and diastolic blood pressure 90 to 100 mm of Hg. Now, if patient has preeclampsia with severe features, then magnesium seizure prophylaxis should be started and it should be continued until after the delivery. And antenatal steroids should be given for fetal lung maturity if delivery is imminent between 24 to 34 weeks of the gestation. Now, how to monitor these patients? Increased monitoring is required for chronic hypertension, gestational hypertension and preeclampsia patients. At least twice weekly BP checkup should be done, and it is done along with fetal non-stress tests, amniotic fluid index evaluation, laboratory test, and if there are abnormal findings, it may indicate the need for early delivery. Definitive treatment for hypertensive disorder is delivery. Delivery usually resolves maternal sequelae of gestational hypertension, preeclampsia and eclampsia. When should we deliver these patients? If there is preeclampsia with severe features, then delivery can be done after the 34 weeks or immediately if patient is unstable. In gestational hypertension or preeclampsia without severe features, delivery can be delayed until the 37 weeks if possible. In chronic hypertension, induction can be done between 38 weeks and 39 weeks. Now, what are the differential diagnoses for hypertensive disorder in pregnancy? When a patient with hypertension comes in pregnancy, then we should keep in mind certain conditions. These are antiphospholipid antibody syndrome, aortic coarctation, Cushing syndrome, eclampsia, glomerulonephritis, hydatidiform mole, Conn syndrome, hyperthyroidism and malignant hypertension. Now, what are the complications in hypertensive disorder in pregnancy? There can be certain complication in mother and certain complication in fetus. So, maternal complications are eclamptic seizures, intracranial hemorrhage, pulmonary edema, renal failure, coagulopathy, hemolysis, liver injury and thrombocytopenia. And fetal complications are intrauterine growth retardation, oligohydramnios, placental abruption and non-reassuring fetal status. So, this was all about hypertensive disorder in pregnancy. If you found this video useful, please like and share the video and subscribe my channel. Thanks.